Estamos a 10 segundos de empezar.
So we are 10 seconds from beginning this part of the morning.
Perfecto, al toque de gong, sírvase conectar, partimos.
Okay,
Vamos a comenzar entonces este segundo bloque
let's begin the second block
con la conferencia Sistemas
with
Automatizados en Días
automated
Enfermos,
systems
Uso de
in sick
Corticoides.
days and use
Un
of
tremendo tema que a
steroids.
todos nos ha tocado
A
vivir,
tremendous
sudar
topic we
y
have
rogar. Por
that
eso me
causes us sweating
tengo el agrado de
and
presentar al doctor
praying.
Bruno Grassi. Él es médico
This will be
internista,
presented by Dr.
interna y
Bruno
doctor en
Grassi,
diabetólogo.
internal
Además, es
medicine
jefe del
specialist,
programa de
diabetologist, and
poquito de
head of
nutrición
the
clínica y diabetología del
program
adulto en la
of
Escuela de Medicina de la
diabetology
Pontificia
of the School of
Universidad
Medicine
Católica de
of
Chile.
Catholic University of Chile.
Bruno, por favor, un placer
Bruno, you're
presentarle.
recognized. Thank you so much, Anita. Thanks to the organizers of this block, which was myself. Thank you for inviting myself. I will try to summarize this topic, and which makes us sweat, and I sweated writing this or making this presentation. Try to structure this. This is a difficult topic because we don't have much evidence-based medicine or clinical studies to support us. So let's start from pathophysiology. We always go back to pathophysiology for tips. General considerations in people with type 1 diabetes to use insulin in sick days, and this is 100% for me how to apply these recommendations in users of automated systems. As a small introduction, I will say what we all know. We all know that when we have disease, when we use steroids, there is an important increase in the doses of insulin in our patients. We all say from general culture that boluses increase more than baseline. We know that this is a pro-ketogenic hormone tonus, and this could lead to ketoacidosis. And we always speak about this with residents. There's a perception that person with type 1 diabetes has to go into sepsis to have great hyperglycemia, but it's enough with a cold, a simple cold, because they depend on the insulin doses we give. So a small cold will increase requirements a lot. And I think this is important. And this is having to do with their self-care. Patients shouldn't require calling us every during these days what to do. They have to know how to self-manage. And on the other hand, our arch enemies, the hyperglycemic drugs and diabetes type 1. My sensation is that we are easily using prednisone in emergency units, respiratory specialists, endocrinologists, and we have to talk with our colleagues to see if it's necessary to give so much steroids. On the other hand, there's a subset of people with diabetes that cannot treat my pain in the shoulder without steroids. Management will have to change, except for 6 days. So I will use pathophysiology to explain this. In acute disease and stress, we will have an increase in counter-regulation hormones for insulin, glucagon, and this increases resistance to insulin. I will stop in that because this is important for the doses. Proteolysis will increase, and when we decrease muscle mass, and this increase in resistance to insulin will decrease in anabolic action and decrease muscle mass and lead to hypoglycemia. When we see the acute effect of steroids, I won't go into the chronic use of steroids in patients with diabetes. In acute use, there are 3 organs we have to look at. Muscle, where we will stress our focus. Steroids generate a resistance to insulin in the post-receptor site, but we also have a drop in muscle mass and also in the adipose tissue. Counter-regulation hormones, especially steroids, will cause lipolysis, which releases free fatty acids to the system and increase insulin resistance. And fatty acids and amino acids generate neoglycogenesis. Here we can infer that this legacy from medicine is that there's an increase in necessity of boluses and baseline. It also has a pathophysiological substrate. When I looked for clinical studies directed to people with type 1 diabetes that use steroids, there is one study only. There is a relatively standardized study, and most problems have to do with, as we talked with Dr. Yersky yesterday, is that one patient receives prednisone, the other betamethasone, other they receive it for 2 months or 5 days, so it's difficult to draw conclusions. This is a study we talked about yesterday. They took 11 people with type 1 diabetes, said they were given prednisone 30 milligrams for 3 days and saw what happened with the doses of insulin. There's an increase in glycemia, and we know that. There is a drop in hypoglycemia. There's an increase in dose of twice the amount, and we have to consider that. But when we see what happened with each patient, it's highly variable. I think that this is the problem we have with these patients. Some patients had an increase, the ones that increased less the dose of 38%, and the ones who increased more the dose of insulin per day 100%. So there will be an increase in glycemia, and we have to double the dose of insulin maybe, but we don't have a cooking recipe. So I went to the hospital where we have most patients using acute steroids. This is a retrospective study assessing patients with diabetes that was decompensated with use of steroids in the hospital, and they reached the glycemic objectives compared to those who didn't. And I want you to see this table. It's a bit complex, but usually we speak about baseline bolus 30 to 50%. I always tell my residents they cannot be at the expense of dropping baseline, but increasing boluses. If you look at the percentage of baseline is close to 30%, but if you look here, the doses, although this does not have significance here, there was an increase in approximately 4 units. And nutritional dose did increase compared to those who did not reach the objective to twice the dose. And that's the idea we have to remember. We have a equilibrium between the bolus and baseline doses, but at the expense of increasing the nutritional dose, not a decreasing baseline dose. And this is important because we mentioned that pathophysiologically there is an increase in liver neoglucogenesis, so dropping the baseline dose has no sense. So I consider the clinical recommendations as well. I'm surprised there is no homogeneity. This is a study that tried to see what different societies did. This is hospitals, pediatric hospitals, and we tried to standardize to see if there was a homogeneity in the recommendations. What to do in sick days? I summarize this. Approximately 2/3 increased DDT percentually to twice as much, and 22% used units per kilogram. Instead of 0.5 per kilogram, it's 0.7 or 0.8. Because I found nothing about clinical studies or very few, let's go back to pathophysiology. Let's put this together with a few data we have, because we have adipose tissue and muscle that became crazy and generated insulin resistance. We will have to increase importantly the bolus dose of insulin to twice as much the dose. We will have to increase moderately the baseline insulin doses. Those are the considerations for any patient with diabetes type 1, patient that gets sick or receives steroids. I won't go into this, but this is important. Let's not forget that this could be a cause of diabetic ketoacidosis. So if your patient has symptoms of ketoacidosis, a patient should be treated accordingly. I want to talk about people who don't have ketoacidosis. We have to tell patients about this acronym. I found it in the internet, but I think it summarizes what we have to do. The patient that has a sick day or uses steroid has to measure glycemia more frequently, not suspend insulin. When I did my specialty, the idea was if the patient has gastroenteritis, it was better to suspend insulin or decrease doses. This is an error. When there's lots of cortisol and inflammatory cytokines, we have to increase insulin, maybe not give a nutritional insulin. The patient needs a lot of fluids and carbohydrates because we have to avoid the things that lead to ketoacidosis, and many guidelines recommend measuring ketones when the patient is sick. So after this long introduction presentation, what can we do in automated systems to integrate this? We don't have any studies, and we mentioned with Dr. Vigetsky that we need those studies, but theoretically, what can we do? Baseline, we have to increase it moderately. What Dr. Astorga has mentioned recently is that we cannot modify the baseline dose in automated systems. We can increase it indirectly, not in our current systems in Chile, Medtronic 180. So we have to, in Chile, trust that the baseline will do a good job and change other things. Option two is for things we don't have in Chile that, from my experience, work with Omniput 5 and do it yourself. We can change the limits of cell baseline. And we can allow the pump to be more permissive. And option three, if things are not working, I will show you some clinical cases, is unfortunately go back to the manual mode and use temporal baseline. We don't have much option in the bolus where we have to work at and where we have to adjust the percentages of dose. We have several alternatives. To increase the nutritional dose to twice the dose, I recommend as a rule for my patients is to increase the intake of carbs, or that's mostly what you can do. This will allow us to increase the nutritional dose. This conversation I've had it with some colleagues. Some other colleagues say, why not decrease the ratio? If you have a cold for 3 days, you don't have to change the configuration. But if you will use prednisone for a month, maybe it's better to lower the ratio because it will transiently modify it. And if things don't work, unfortunately, we have to go to manual mode and use the override. As I mentioned, most of this is what I recommend. And for the system we mostly use in Chile, MM780, in terms of cell baseline, we have to trust it and ensure that patient is using adequate settings, and to use it during steroids or inflammatory cytokines. They use an aggressive pump. If the patient is in 120, use 100 and trust the baseline. And of course, not activate the temporal objective because this will set to 150 and the patient will go higher. This is a worst scenario in this case. In terms of corrections of boluses, ensure that the having the most aggressive setting, lower active insulin 2 hours so that the system uses self boluses. And I recommend to put 1.5 or twice times the carbohydrates they are eating. Our system that we have in Chile has a self-bolus system. If it estimates that it will cause hypoglycemia, it starts using percent boluses, and you can see this in the graph. Unfortunately, that's all the scientific information I have to give you about this topic, and now I will go to clinical cases. If you like drawing in ChatGPT, it's fun to draw how you imagine your patient. These are one of my patients. I described ChatGPT, how my patients were, and ChatGPT drew it. Here's a 21-year-old man, diabetes type 1 since 2008, 90 kilograms, height 180 centimeters, therapy MM780, excellent metabolic control, HbA1c 6.6%, TIR 885, common cold between 19 and 23rd of April 2024. This is a sum of what happened. Here we are comparing in the blue bar the sick days, and in orange bars the days after sick days. And we lose some time in range, and when people are using steroids, they will have hypoglycemia, will lose time in range, but we are still in the target range. The total dose increased in almost 50%. The cell baseline we have to trust in, and was able to increase in 51% during those 3 days. And the bolus doses has increased 45%, and because the patient said he was eating 30% more carbs than what he was really eating. These are the healthy days. We have time in range 90%. Basically, patient ate normally. These are the days before sick days. And here we have the days that patient was sick, DDT 134 units, time in range 65%, and the patient had to put many carbohydrate loads. The patients had to put false carbohydrate intake, but the results are quite good. This is in a patient if the patient didn't have adjustment, time in range would be 100%. So we modify the carb intake, and we have decent range. Second case, this patient wouldn't like to be seen as ChatGPT described. I described her ChatGPT. This is a 49-year-old woman. She has type 1 diabetes since 1982. She is thin and she has multiple sclerosis that is being treated. She receives a biological agent. I don't remember the name. She is also using Minimed 780, good metabolic control. But every time this biological is given, she requires 2 days of betamethasone intravenously. Once again, we zoom into our results. We lose time in range, generate hypoglycemia, and we think we have to educate the patients. When I give this speech to them, I say we will have to tolerate some hyperglycemia, but the idea is that you don't reach 400, but around 150, 180 with the technology we have today. We lose some time in range. Once again, the pump adjusts and was able to increase in 50% the total day dose. Self-baseline increases 36%, increases boluses 60%, and she increased carbs 1.5 times. And I recommended to double carbohydrates, but she increased only 1.5. This is her usually 90%, 95% time in range. So she doesn't like to drop 70 to 75% time in range. And this day she did exactly what I said. She's a small woman, this bolus of 100 carbohydrates. This is not what she eats usually. And I also talked about this. She could see that these days the more convenient thing was to have an intake of low carbohydrates. Maybe it's a good idea in the sick days or using steroids to reduce the real intake. And when she used betamethasone, she could increase her time in range to 89%. So let's remember not to forget nutritional strategies. If a patient is using steroids or sick, maybe it's not the best day to eat sushi. Finally, this is the case we have to show because it doesn't always work. This is a patient my friends from Clínica Alemana, this 39-year-old man, type 1 diabetes since 2014. This is a man who has his own company. He's an influencer about sandwiches and pulled pork and French fries and does reviews for some restaurants, and he trains a lot, but he lives in that setting, eating. He's not a healthy eater, really. He uses a Minimed 780, good metabolic control, and he went to see a ENT specialist, and the ENT specialist was going to do nasal surgery and indicated an anti-inflammatory diet prior to surgery. He reduced carbohydrates, etc. And here we did badly with the strategy. He is including twice the carbohydrates, lost 31% of time in range. DDT increased 66%. This is 2 weeks before surgery. His boluses increased almost 100%. His dose of carbohydrates at 65%. And in spite of this, we couldn't achieve our target. Here, he is injected steroids. He goes to surgery. He received a bolus of dexamethasone, temporal target during surgery. This is what we recommend during surgery. And there is no hope here because he still has several boluses in the pump in spite of increasing the dose up to 36. So the next day, 50 units, and he is not within range. And the next day, his dose, in spite of with a pump increasing 3 times to 73 units, he doesn't achieve the target. And he called his treating physician, and the physician said, 1% time in range, you need to go manual. And with this, he increased the baseline, he used a temporal baseline and went back to time in range. So applying these considerations, a temporal baseline at 150% and increasing the bolus dose or modifying the ratio. In spite of this, he continued receiving prednisone for several days, and it's not that this is a holy grail. In manual mode, he didn't achieve his targets, so we have to consider these interventions. It's not perfect. With steroids, sometimes it's hard. And what happened here? Famous anti-inflammatory diet. It's not the diet that he uses. This patient eats hamburgers and French fries and started eating broccoli and chicken the 7 days of surgery. And we have to understand how our systems work. And this is based on total day dose. So he dropped artificially his total day dose to 24 units, and he used a 36 or 40. In real life, he dropped to 24. So he has a very low DDT with low ability of self-correction. So what happened is that DDT had to increase in 157%, still baseline 100%, a bolus is 205, and in spite of this, did not reach target. My recommendation to the patient was that first, I'm a specialist in nutrition. I thought that the anti-inflammatory diet is not working respectfully, and even because you eat hamburgers and French fries usually in this setting was not a good idea, I thought, because it failed. So just in time, I used my clinical cases. So let's remember, during infections and during use of steroids required adjustments in the dose of insulin type 1 diabetes patients. Steroids increase perolysis and lipolysis. This increases massively peripheral insulin resistance and is a substrate for neuroglycogenesis. Observational data in type 1 and type 2 diabetes in the hospital showing important increases in bolus doses and moderate and baseline bolus and baseline doses, but this is different among patients. We have to increase mildly the baseline dose with the multi-dose or automated systems and increase bolus doses in our therapy. Let's not forget a recognition of diabetic ketoacidosis. And in automated systems, we can trust so baseline increase artificially the nutritional boluses through ratio or lies. This may not give good results, and we have to go to manual mode. The patient will be a bit overloaded, but this is a difficult situation. We have to educate the patients, tell them that the figures will not be as good as usual. And this is my email. If you are scared about AI, look at this thermometer and the patient looking at it. This is AI. So AI is not ready yet. Thank you.
Muchas gracias. Muchas
Thank
gracias, Bruno.
you very much, Bruno. As always, very interesting and educational.